Hello everyone. Today in our series of Docplexus KOL interviews, we have with us Dr. Roger Mazze. He is the Chief Academic Officer of the International Diabetes Center. He is widely acknowledged as one of the most important innovators in the field of diabetology. He has made several contributions towards improvement of diabetes care and patient outcomes worldwide. He has been serving as the head of the WHO Collaborating Center for Diabetes Education since 1988. Dr. Mazze has also developed a diabetes disease management system called Stage Diabetes Management, which is implemented in more than 400 clinical sites throughout the USA and in 69 medical centers of Indian Health Service. Thank you so much, Dr. Mazze, for joining us today.
Thank you.
Please provide us some more information on the globally implemented project called the Stage Diabetes Management.
Thank you. Stage diabetes management was initially developed in the United States for primary care management of diabetes. As you know, type 2 diabetes particularly is rampant around the world. In the United States, about 80 to 90% of those individuals with type 2 diabetes do not see a specialist, they see a generalist. So several years ago, in the late 1980s, we decided to take on the initiative, first within the United States and then globally, to develop an evidence-based approach to diabetes management. And by evidence-based approach, I mean a systematic, widely accepted perspective on how to approach the diagnosis and treatment of type 1, type 2, and diabetes in pregnancy, recognizing that although within the United States, type 1 and diabetes in pregnancy are generally treated by specialists, in most countries around the world, all forms of diabetes are treated by generalists, individuals who are not specially trained in endocrinology nor in the subspecialty diabetes. The approach is algorithmic based. It begins with the notion that there is ample evidence to determine the sequence of treatment regimens. If one treatment fails, the next treatment is initiated. And because the evidence-based medicine approach requires substantial data to make the decision, we promoted right from the beginning of the development of stage diabetes management the entire idea of patient self-care and the notion of patient self-blood glucose monitoring. At the time, the kind of monitoring that was available was rather rudimentary, using strips to measure blood glucose levels at random times throughout the day and in some cases overnight. Very inconvenient for patients, also very painful and quite costly. In addition to that, the data that was collected from the patient was often subject to error. So here were physicians following an evidence-based approach to diabetes management, but the evidence they were receiving was often erroneous and mistaken. So one of the first things that my group did while I was still at Einstein Medical School was to develop what is known as the second generation of reflectance meters, the meters with a memory. This enabled us to develop programs to capture glucose data from these meters and make them readily available to physicians in a reporting form that would compel them to make a clinical decision. And I use the word compel because many physicians, for years it has been known, are intransient about diabetes management. They stay with one therapy, sometimes blame the patient for not advancing. Patients are reluctant to start therapies that they perceive to be either more painful or more dangerous, such as therapies that lead to hypoglycemia or injected therapies. So because of this inertia, because of this lack of movement, when we developed stage diabetes management, the whole idea was that if you reach a point where you have not reached the goal, you must move on. You cannot stay still. And so when we developed this system for representing glucose data, it was done in such a way that it would show a graphic of how well controlled the patient was, essentially compelling the doctor to do something about it.
So what are your recommendations about the ambulatory glucose profiling in clinical practice?
Well, I'm glad you mentioned that. Ambulatory glucose profile was this reporting system. As I mentioned, we started using it with self-monitored blood glucose, and self-monitored blood glucose has a number of tremendous difficulties. One, it is often misreported by the patient. Two, even when it is electronically collected, the patient chooses when to test and often misses overnight periods. So 1/3 of every 24 hours has no data. You can't make a clinical decision unless you know how the therapy is working overnight. By the early 2000s, continuous glucose monitoring was introduced. So we applied ambulatory glucose profile reporting and analysis to continuous glucose monitoring. Now we had 288 readings for each day. We had readings for overnight, daytime, postprandial, after exercise, before exercise, under situations of illness. And those pieces of data now became the core to stage diabetes management, in the sense that to make a clinical decision that's accurate, that's appropriate to the patient, and hopefully beneficial. Now you have the evidence by looking at a profile that truly represents what is happening to the person now and what will continue to happen if there is no change in therapy. Going back to our original notion with stage diabetes management, to prevent the physician and patient from staying in one place. You keep moving until you reach the goal. Now, clearly with ambulatory glucose profile, the goal has become more definable. We know what normal looks like. So we know what we're trying to achieve on the part of a patient with diabetes. And again, type 1, type 2, diabetes in pregnancy, children with diabetes, non-insulin treated patients, insulin treated patients, and now even individuals at risk for developing diabetes. So we can do that with ambulatory glucose profile. And in the future, we're hoping that as the technology improves, for instance, there are now continuous glucose monitoring systems that don't require calibration. The sensor lasts for 2 weeks rather than for 1 week. And perhaps one day the sensor will last for a month with no requirement for capillary testing whatsoever, and with accurate enough data that making a clinical decision will be much easier, both for the patient on a day-to-day basis of what to do. Shall I eat this, not eat this? And on the part of the clinician, over the long run, in making sure the patient optimizes their control.
So are you trying to conclude that the glucose monitoring systems that we're using nowadays are reliable?
I believe they're far more reliable than urine testing was, than capillary testing was. So I think it's incremental. I think the idea that they have to be exactly the same as what you would find in a laboratory is an ideal situation. And we're moving towards that. There's no doubt about it. But even now, the data are sufficient to assist in making a clinical decision that's far more reliable in terms of producing a good clinical outcome than previously, when one was dependent upon biased data or urine testing or patients just making everything up in a little notebook and handing it to their physician.
So is it possible to monitor the blood glucose subcutaneously to determine the trend in glucose level fluctuations?
There is an issue. In all of the continuous glucose monitoring systems now use interstitial glucose measurements. Interstitial glucose is not blood glucose. However, there are some who argue it's more accurate, more reliable, more dependable, in the sense that our brains are floating, literally, in interstitial fluid. They're not floating in our capillary blood system. So which is more accurate? If you want to know how much glucose is around the brain, then wouldn't it be nice to know that you're using the right measure? There are those who would argue because of the difference between blood and interstitial fluid, we should not rely on continuous glucose monitoring until it's far more accurate. Well, that's a bit silly. An X-ray was far better than feeling if a bone is broken.
Yes.
An MRI is better than an X-ray, okay? But as you move, you progress. If you go backwards, and if a doctor said, well, an X-ray isn't exactly accurate, I need something more accurate, and went back to feeling for a broken bone, that's what we're doing when we go backwards. When we say SMBG is more accurate to a laboratory reading than perhaps interstitial glucose, we're going backwards, honestly, because there aren't sufficient readings. If you miss overnight, how can you say that's more accurate than a system that gives you overnight but maybe 5% off? And it's also relative. Is 5% make a big enough difference? I don't think so. Not for a clinical decision in most cases.
Definitely, I completely agree with you on that. And thank you so much,
Thank
Dr.
you.
Mazze, for sharing your valuable expertise on our platform.
Thank you very much, and thank you for the invitation to the organizers of the conference for allowing me to come here and share my ideas.
Thank
Thank
you
you.
so much. To stay updated on our latest KOL videos and interviews, please follow us on Twitter, like us on our Facebook page, and subscribe to our YouTube channel. Happy Docplexing!